for this time off. Would have been nice to have a little bit. We've had early on, we had to stay in the house. We had really good rain.
Yeah.
We have to go out a little bit. It seems to be, we had really good weather. Now we're going out. It seems to get a little bit rainier.
You know, it has definitely helped people's general mood. Okay.
I think everybody's, we all know that we're in the same boat. We don't have too many, you know, bad, evil people walking around like you may see in the news. The worst thing I'd say is there are people who are a little obstinate about wearing masks. So when they go into stores, you know, they, it seems like some type of a ego thing or a protest, but maybe 60% of the people are wearing masks and social distancing like they should.
Yeah. So just you know, so I don't want to. So consultant for the NY City Ballet, New York City Ballet, and then you normally at the end I just say well, when we're finishing up, thanks very much, Tom, and you know how can people find more about you? And you'll probably give them just your website.
They'll find me. You my name, and you know, like I'll give them the website if I remember what it is. I update it, but
it'll
be all right.
Okay, ready to go?
Yeah.
Cool. Okay, so let me see. We'll get this going. Great. So good afternoon, everybody, and welcome. So it's afternoon time here in Dublin, and we are now live with Tom Novella in New York City. So good morning, Tom. And so I first encountered Tom when he came to lecture in the UK at a biomechanics musculoskeletal conference in the summer of 1999, way back in 1999. And what intrigued me about Tom, which we'll go on to speak about later on, was the notion of somebody having a too good foot, too good dance position, which when we're training, it's always about restrictions and something is bad, but the too good intrigued me. And then also the day in the life of the dancer and how that, you know, those elite athletes, you know, it's a brutal game for the dancers to work in, an environment to work in. And so, you know, Tom would have described, you know, to treat the dancer is to work in the gray zone, you know, a zone which neither over-treats to such an extent that you're going to, more harm would be done, nor under-treats to a point of being ineffectual. And when the dancer comes to visit, the only one question is exactly when I can safely return to dance.
Yeah.
Tom is a professor of orthopedics in NYC, consultant to the New York City Ballet. You can check out his website. I mean, the list goes on and on and on in terms of lectures and talks and training that Tom has done. So Tom, welcome.
All right, Justin, thank you. Thanks for having me. This is fun. Much looking forward to our talk today. So
yes. So how's things been over the last period? It's a strange world we're living in.
Yeah, past 10 weeks, it's been a bit slow here. You know, the whole city was locked down for the whole month of April and last week in March. Starting to pick up a little bit now in terms of seeing patients. New York City's opening up a little bit. I'm an essential worker, so if there were emergencies or whatever, I'd meet people in the office. And I have a couple of days on the schedule next week. What's it like over in Ireland?
Yeah, Ireland, we're starting to get, I don't think it certainly wasn't as serious, well, whatever, you know, how serious can this global pandemic be? Clinics, excuse me, in terms of podiatry-wise, started to reopen again for certain patient groups after triaging on the 18th of June, in May, sorry. And there's a gradual reopening. I mean, certain colleagues were seeing essential diabetic patients and things over time. I mean, that didn't stop, but I know colleagues in the National Health Service and the Health Service here in Ireland, of course, they were just not as usual, but you know, restricted outpatient visits, but high-risk patients was. So yeah, it certainly is strange times that we live in.
Sure, I saw some dancers actually during this lockdown, as we call it. And funnily enough, and you know, I guess there's a couple of silver linings out of this. A lot of these injuries are starting to abate. many of these dancers that I've seen over the many years, I mean, they've been inspirations since I started seeing them in 1978. But many of these dancers will dance for years through
Yes.
injuries,
Yes.
and they never give themselves a chance to rest. And because nobody's performing right now, it's an enforced rest. The
Yes.
demography of injury I see right now, oddly enough, is more young kids trying to get into dance that are trying to learn virtually from teachers who do like as we're doing today, you know, Zooming and
Zoom
stuff.
classes and
The problem with that is that sometimes when they try to take their lessons, they're taking them at home, and the floors are not very good.
yes.
So instead of being a sprung or soft floor, they're trying to do some dancing and jumping and various
Well,
movements.
that one question when I was when we planned, because you know I managed to track you down over time. Well, you say you're not hard to find, but it was just through my own course notes that we were going through. But one of my thinking, you're saying that's pretty interesting about the dancers and enforced rest, because you had to get them to rest or scale back. And I've dealt with runners in the past; they don't want to. But how will that, because they're not going to be as conditioned now because of the lockdown to actually go back and perform to that level when they give them the go ahead to safely reopen. So if a show starts to reopen, say, you know, they're not going to do 6 nights and a matinee on a Saturday. So there's going to be that increase before to get back to that level as well.
Yeah, well, I think it has. I think the lockdown has an inbred safety zone. I've just finished treating a dancer who had to take him out of the Nutcracker this winter because he had a partial rupture of his plantar fascia. And I've been giving him, I don't know, you guys do shockwave or laser treatment and things like that much over there. And I've been giving him quite a series of that. And we were trying to figure out before the lockdown how he was going to get himself back to dance as quickly as possible. Well, you know, all he has to do now is just wait for it to open up and start doing the exercises the physical therapists are showing him. And he's a fabulous dancer, but there's an built-in ease into dance now because nobody's performing. I don't think that's much of a worry. Shouldn't be.
Okay, right. And and so tell us a little bit more of your story, Tom, in terms of how you.
Okay, well, I was lucky. I mean, I had done a pediatrics, I did a surgical residency, I did a pediatrics fellowship, and I was doing a biomechanics fellowship at the podiatry school. And near the very end of my biomechanics fellowship, one of the chief residents asked me how I would like to get into a dance medicine clinic in New York City. And to me, it sounded like a great opportunity because even when I was in high school, I was reading articles in the newspaper about ballet dancers who would go to the theater on crutches, perform, and go home on crutches. And that's one of the reasons I got into podiatry. I said to myself, that's the kind of person that I want to treat. And sidebar, that's the kind of person that I've been seeing. I've seen 35,000 dance encounters, and every single one of them to me is like a little demigod. You know, they're such professionals, and they believe so much that they can and that they can get better, and you just can't tell any of them to stop dancing. They're only a very few have ever made up their mind to stop, and nobody has ever stopped the few that I asked them to stop. But getting back into it, so I started working in that dance medicine clinic with some alternative health people. There weren't really too many dance physicians around at the time. So I was seeing up to 20 dance patients a day, trying to apply what I learned in my biomechanics fellowship, which was really about baseball players and runners and things like that, to dance. And I found that there weren't too many corollaries in terms of range of motion that you learn in podiatry school. So I got into my own analysis of the requisite dance ranges of motion. And I studied in the first few years about 1,200 professional dancers. And I set up a protocol and a measurement technique, which is now used around the world in terms of accurately measuring plantar flexion and dorsiflexion in the ankle, and also a database of the requisite amount of range of motion for all the different dance genres, which I've been lecturing about for many years. And I still use.
That didn't exist then before that. There wasn't any dance medicine journals. You know, you were at the start of the field.
Yeah, right. There was not, there were a few well-known dance orthopedists and maybe a couple of dance podiatrists, but what I think I contributed, at least to my practice and all my patients, and hopefully to the people that I lectured to, was the looking for requisite ranges of motion per chosen activity, including dance. And it's been a lot of fun. So there I was, and then I actually was lucky enough also at the time to work with a physical therapist and a world-class runner, and we started seeing a lot of Adidas world-class and Olympic athletes around the same time too. So I really had I mean, it wasn't like I was good, I was just lucky. And I just started and I continued, and I've been doing it ever since. I don't do surgery, even though I did a great residency, because I just love what I do. Is kind of Sherlock Holmesy and getting to the cause. And so and this has just happened for the past 42 years. So here I am.
Here you are. And yeah, that was interesting. And to say some of the lectures we had with this Too Good Foot, and yes, that day in the life of a dancer, or that dedication and commitment from a very, very young age, and then but then and then of course it becomes a lot more serious at 12, 13, when they start to go into the schools, and that whole journey. I mean, but the drive and the passion.
Sure. Well, you have to have that. I mean, I've talked to a lot of dancers and a lot of choreographers and a lot of dance teachers, and I said to them, can you tell when a little kid gets into a dance studio if maybe they've got enough to go all the way to have a professional career? What do you look for? One teacher said to me, well, they have to be able to respond instantly to changes in choreography. And if they can't, they're not going to have it. Another thing is that they have to have musicality. In other words, that body has to move naturally to the music. And another thing which has touched me the most, and I'll tell you about this particular dancer's story, he said to me, when that little kid walks into the studio, it has to feel like the most special place in the world. And, and you can see that in the child, how they feel. And this particular dancer had been seeing me for, a couple of years, working really hard to get severe forefoot malalignment and unstable joints. And his foot basically fell apart as he was dancing through it. He had a major forefoot reconstruction in his early 30s. And I thought I'd see him back up on stage. And I did see him on stage about a year and a half after he'd had that surgery. And it was just like one of the most inspirational things in my life to see what he did to come back. And he was not going to stop dancing until he was ready. So, I mean, and I see this all the time. It's just,
you have literally seen somebody in through the theater door on crutches, nearly sort of carried in, perform, and I mean, it's that amount of dedication.
Right. Well, that actually, I haven't seen them come in on crutches and perform. I've read about somebody who came in on crutches many, many years ago. And actually, I wound up treating him and his wife years afterwards. But that's what inspired me to get into it.
Yeah, but that's what you mentioned. Yeah. And I mean, anybody, no matter what elite athlete is, or what patient group we're dealing with, whether it's elite cyclists or skiers or runners or dancers, there's always a niggle. There's always something that just isn't right. They're never, very, very few, especially at that level, or ever.
That's, it's always something. I mean, this is really, as I say, a blessing in disguise. I mean, I'd like to give an example of something that I see very, very often, which is the compounding compensatory injuries. And usually it's with this Flexor Hallicus longus, which you guys are all familiar with, and your FHL. It's a very important motor unit in a dancer. The FHL will toggle someone between, let's see, I have a skeleton here. Helps toggle the foot from demi-point to full point, demi-point, full point. So it does that. It's the primary medial stabilizer of the ankle on point. It shares the work with the FHB to protect and stabilize the first MTP joint. It works with the posterior tibial to slow down shock and slows down pronation to absorb shock. And it helps to generate leap, and it's an accessory plantar flexor of the ankle. And it also happens to be frequently misdiagnosed. Very often people come in, they've seen a few people already, and they've been diagnosed with plantar fasciitis or posterior tibial tendonitis or posterior ankle impingement syndrome or Achilles tendonitis, depending on the area of involvement of the FHL.
Yeah.
And that may not be the primary problem, although, and more confusingly, many of these injuries can occur simultaneously in combination with the FHL. But getting back to the FHL, and the reason I'm pointing this out is it seems to be the most unheralded, yet among the most common injuries that dancers get. And I really would love to get this point across to your audience for the sake of all the dancers that they're going to be.
Because we have got, some, I can see people on who are watching who do a lot of dance medicine. But just before we get on, I know it's a very important point, Tom. Yeah. I think a lot of colleagues don't realize, maybe we, again, when in our training, basic training and things, we don't get the exposure to the range of patients that we do in the real world in clinical practice, and especially within dance. And I mean, just the ability, the training to be able to spend 6-8 hours a day on point, the explosive nature of the of dance, to jump and to land and to and again, right across. I was lucky enough to work with some Lindy Bop dancers. Yeah. I mean, they're just absolutely amazing, and it's fantastic to watch. And I love the music as well. But the force is generated, and it's the stresses on the joints in the body are just.
Well, just as you're saying, it's just as you're saying, it is amazing the stresses that occur with dance. But the other thing is, even though one may never see a dancer, the things that I've learned from treating dancers, as we said in our chat before we got started with our Zoom today, are things that you can extrapolate to your regular population and learn things to look for.
So, so Flexor, Hallicus, Longus.
So on the FHL, for example, just to diverge for a second, and I want to tell you, I want to get into it in a little bit of depth because I think it will be very helpful, because I've seen it so often in regular population too. If you have a verifiable forefoot varus, you're more likely to have a FHL tendonitis, especially if it's caused other problems. Let's go real simple. If you have a forefoot varus that's caused some fifth metatarsalgia from compensation, one of the things I've noticed that people do to try to bring the weight back to the medial part of the foot, but stop the aggregate problems that can say happen to the hips or knees from a forefoot varus is they hyperplantar flex their great toe, kind of like an extrinsic forefoot varus post on an orthotic.
Yep.
And doing that, it can engender with the forefoot varus and a resolute forefoot varus, not one that you may be able to manipulate away, especially one that's caused other mechanical problems than the metatarsalgia. They'll get a FHL tendonitis, usually under the metatarsal from that. But just to get into the vast array of associated problems and things to look for with this FHL tendonitis, it is called the dancer's tendonitis. Besides the difficulty in diagnosing it by palpation, don't forget it goes under the metatarsal, sustentaculum tali, and then retromedial-malleolar posterior ankle. One of the first things that I look for with FHL tendonitis is weakness in the peroneus longus.
Yes.
And the way I check that, and it's a particular way to check it, and I'm very principled that this is something that I want to get across to your audience too. When you check the peroneus longus, which it obviously is the primary lateral stabilizer of the ankle when you're on demi-point, which is on the belly or point, the peroneus longus. Check the strength manually with the foot in plantar flexion and the toes in plantar flexion. If the toes begin to dorsiflex, you are checking the extensor digitorum longus, not the peroneus longus. So when somebody, I do my manual testing, I've got my both hands on the picture here. The foot is plantar flexed, this one. The ankle is plantar flexed, and then I'm resisting them everting. If their toes dorsiflex, I say, nope, keep your toes down. Nope, keep your toes down. If their toes are in plantar flexion and the ankle is plantar flexion, if I can break their strength, I know their peroneus longus is weak. And and I'm going to tell you the import of that in a second, but just to continue on with the peroneus longus, the same thing has to happen with strengthening. If someone has improperly strengthened their peroneus longus, they will be more prone to perpetuated FHL tendonitis. Proper strengthening of peroneus longus is exactly the same as you tested. A TheraBand, foot and plantar flexion, toes and plantar flexion. Do not dorsiflex the ankle, or you're strengthening the EDL and the anterior tib. Ankle and toes and plantar flexion with the strengthening with the TheraBand. Why is a strong peroneus longus important with FHL tendonitis and a lot of other injuries that you see in dancers? Well, first of all, the most common injury that dancers and soccer players and basketball players and a lot of athletes get is a sprained ankle.
Yes.
Most dancers come in with this, again, like I said, gray zone sprained ankle. There may be a little bit of laxity, maybe 1.5 up to a 2/3 laxity in the anterior talofibular ligament, maybe a little bit of shift, but they've evolved a conundrum of a weakened peroneus longus because plantar flexion will be unstable. The posterior aspect of the talus is narrow in the mortise. A weakened peroneus longus, and they get a weak calf too, because again, they're not so prone to plantar flex unless they really have to, but somehow, and that loses strength in the gastroc. And just continuing on with this very important point for another 3 minutes. Okay.
No problem. I mean, this is golden for anybody who's working with dancers.
Okay, not only dancers though, in your regular population.
Sorry.
Okay. So,
and again, as you say, so a sprained ankle is the most common injury that is pretty much seen across the board, and the whole sequelae of what happens from that.
Right, and I'll talk if we have time about shoes and the generic injuries per dance genre. I know that's one of your questions that you had too. But just to finish this point with this FHL tendonitis, not only have they evolved a weaker peroneus longus, which weakens obviously after the ankle sprain because you're not using it that much, they've also evolved a weaker calf muscle. And you can also check the calf strength, not only by manually resisting plantar flexion, not of the toes, but at the ball of the foot. And you should not be able to break that. You have to resist the strength all the way through the range. But you can also check calf strength by watching a person walk. And if they've repatterned their walking to avoid throwing the weight forward, not only because of, say, a sprained ankle, but because of some type of metatarsalgia, you'll see that they don't really push off. They don't have that magic moment of push off. It's the hardest thing to look for in a gait analysis, yet it's the most important thing. They sort of they just get to a certain point in mid stance, and then they hyperflex the hip and they pull the foot off the ground without thoroughly pushing through. So both feet are on the ground at the same time.
Yes.
So that's another thing that you look for. So just to get back into proper strengthening of this, and you may have to, I don't know if you guys do prolotherapy over there.
Yep.
You guys do prolotherapy, you may have to give a prolo shot, and it really works great to get the ATFL back into neck properly. But
just to settle down, dampen down the inflammatory processes going on.
yeah, and it's just like sugar water, lidocaine, stir water, diluted. It's important that it be diluted. But proper strengthening of the calf is also important, because let's say you find somebody who has a weak calf, a dancer that has a weak calf. Okay, we'll start doing single leg heel elevations, on the ball of your foot. People call them toe raises, but obviously it's really heel raises. If you do it straight from the ground, you're going to be encouraged to continue the compensatory pattern of overuse of the FHL. So what I have people do when they're doing their strengthening is I have them get a dense half foam roller, and they strictly put the ball of the foot on the apex of the roller without allowing their toes to overwork. And that's how they go functionally down and functionally up. And that's how they really get the calf stronger, and then the peroneus longus strengthening exercises too. And you'll often see impingement injuries in the ankle because of the extreme dorsal and plantar flexion ballistically, especially in a ballet dancer. And the weaker calf can lead to more anterior impingement in the ankle, which is another not uncommon.
Because the talus is so anteriorly tilted in that point and demi-point position.
Right. Oh, so it's anteriorly tilted, and that's actually one of the reasons why your ballroom dancers prefer. They usually have a higher arched foot, which is perfect for a higher heeled shoe. Flatter foot, not as same as it is for ballet. a flatter foot is more likely to have an impingement in plantar flexion, and a higher arch foot is more likely to have an impingement in dorsiflexion because of the calcaneal inclination angle. You can visualize that.
And of course, then yes, with a lateral ankle sprain, there is that anterior shift then of the talus,
That's
which
right.
yeah, which leaves the joint, because there's no ligaments around to actually control the talus itself. So
With that,
if you have that up,
sorry, the anterior shift is, and that's just, I'm glad you brought that up because there's just so much, we're never going to be able to cover it all, but just since we're still talking about this ankle extreme range of motion and an ankle sprain, people who've had, say, mild anterior laxity in the ankle due to an ankle sprain sometimes get what's called posterior impingement, which I'm sure you guys are familiar with, in the ankle because of the excessive, and this has something to do with that too good foot that you mentioned, excessive anterior displacement takes place in the ankle when you lose the anterior talofibular ligament strength. And that causes the trigonal plateau to abut the tibial plafond, creating a posterior impingement injury without any accessory ossicles on the back of the ankle. Just something to look for. And then it's amazing how if you find somebody with a little bit of laxity and they have posterior impingement where they've never had it before in their dance career, and there's no ossicles or anything like that, you can get rid of posterior impingement by firming up, say with prolotherapy or PRP, which I never use if necessary for this particular injury, the anterior talofibular ligament, and there goes the posterior impingement. Just a sidebar, many more that we could add to that. So what do you have to say now? I should listen to you now.
Well, a couple of questions are coming in, and Sarah Jane wants to know, in terms of assessment of the flexor lucis longus, how do you recommend we assess it? Well, we went through that, and then as we correct, would you go to tib post or PF with these injuries? Would we go to tib post? Yeah, so but you're going to re-strengthen it all around the whole,
sure,
the whole ankle structure. Yeah.
You will.
Yeah.
But
and then Megan wants to know in South Africa in terms of pressure. I'm sure you've looked at dancers on pressure plate assessment over time, but I would have thought in terms of that wouldn't be a normal day-to-day sort of assessment of the dancers.
No, I've not gotten into too much pressure plate assessment. I kind of like old-fashioned. I like to watch their actual technique and maybe watch them walk and just check their strengths and range of motion. But I'm an old guy, and I don't know how to extrapolate this into real-time data. But it's just not my bag, And I think there's a lot of research going on. There's the International Association of Dance Medicine and Science, and I think they've done some studies on that. Anybody who's interested in such things may want to join the IADMS, International Association of Dance Medicine and Science. They have a wonderful journal with lots of research on it like that.
Yeah. And of course, things are continuing to sort of develop all the time. And then high volume injections for tendonitis.
High volume injections. What do you mean by that?
And well, there's a couple of specialists in the UK. So it is instead of, if you were injecting into, say, the tib post, you would use a maybe 30-40 mil of sort of saline and things, and it actually it strips where you get the adhesions on the sheath on the nerve, and it sort of strips the nerve, or not the nerve, the tendon up. So they're injecting the lidocaine with probably a steroid, but with like maybe a 30-40 mil bolus to really sort of free up the tethering around from the sheath on the tendon.
That's okay. Not within the tendon itself. Yeah, trying to elegantly using ultrasound guidance to get the needle between the sheath and the tendon to free up any adhesing tenosynovitis or anything like that. That's something that I usually send people to an interventional radiologist for that. I use my ultrasound machine for certain things. The people that are better at that than me would be interventional radiologists. Yeah, sure, I prescribe it.
Yeah. No, in Dublin, I was using a couple of key guys, and I know colleagues, UK and Ireland, the others, they've got their pet radiologists for this, and then there's a lot who don't do it. So I mean, it's it's pretty specialized. It's
a good technique as long as you respect the tendon. Being very careful not to enter it with the steroid, And if you especially, for example, it's not unusual to have an FHL tenosynovitis, say inferior to the sestentaculum tali or even the first metatarsal. And the best way to access that tenosynovitis with cortisone is actually to enter the tendon sheath in the retromalleolar area. And just a little bit of use will spread the cortisone all the way up and down the course of the tendon. So yeah, it can be very helpful.
Yeah.
And
where did we go? So that's but that would be in your overall assessment. That would be the FHL would be one of the key components of your assessment.
If it's indicated, yeah, it will. It depends on people come in with a myriad of problems. Dancers can have plantar fasciitis, as I say, a ruptured fascia. They can have a heel contusion, a stress fracture of the heel. Peroneal injury is very, very common, especially the retinaculum sometimes tears and peroneal injuries. You can have a posterior tibial tendonitis. It's not that uncommon, but there is a greater frequency of FHL tendonitis in addition to posterior tib. You're asking me about strengthening a little bit earlier. I wouldn't, one of the problems with dancers is they tend to overstretch and they tend to overstrengthen. And I wouldn't give them like too much strengthening of a posterior tib if it's already strong. Maybe I'd give them some glute max strengthening to help supinate.
Yes.
But
because that was it back in 1999, and pretty much we concentrated from sort of mid tib down. And that was the scope of practice, and it was always and then certainly as my career developed, and it was all core and trans abs and glutes and everything. But you were again at the start was, and in terms of that too good foot and the turnout in first position, that was. Then you were looking at pelvis, you were looking at hip, you were looking at right the way through the chain. Actually, we were always like focused on the foot. You need to get up and look at the whole body.
We had a big celebration in 1975 when we got out the champagne when we realized the foot was connected to the rest of the body. So it was just a wonder. We had a big party that day and everything. But I should say what the too good foot is. I think people may be a little bit interested in it. Dancers, there's a hierarchy in dance. At least there used to be. A thin dancer, for example, is on the top of the pecking order. The thinner, the better, although they're more prone to injuries. And another thing that establishes a pecking order in ballet dancers, male and female, is how much plantar flexion the talus has in the mortise. And the greater the plantar flexion, the more coveted that particular shape is. Unfortunately, too much plantar flexion will take those peroneal tendons that are notched. We just spoke about the retinaculum a second ago. Too much plantar flexion actually takes the peroneal tendons and removes them. Removes them from the notch. So you actually lose instability because the peroneal tendons are no longer anchored by the fibula, and that's called the too good foot. So it's like another one of the can't win for trying things that you see in your highly dedicated athletes or dancers.
Yes, and again, yes, but position, but and where they're able to sort of cheat their restrictions in certain positions.
The whole thing is cheating. I had a kid from City Ballet who came in to see me. She had, oddly enough, a stress reaction at the cuboid and calcaneal joint region. And the problem was she had lost some of her external rotation in her hip. So to indicate that she looked like she had more external rotation, eventually she was cured by getting her glutes stronger, which were like the primary external rotators. But to make it look like when she was performing, she had more external rotation, she actually had to wing out her foot or hyperabduct her foot when landing, and that caused an impingement injury in the lateral midfoot, which eventually led to a cuboid calcaneal stress reaction.
Yes.
So, that's one of the typical cheating things.
Yes. And the other cheating thing, the other, as you said, there's the hierarchy with the dancers, but a lot of it is the aesthetics of the arch and of the foot profile and that falls in now then to footwear as well. And I know that was one of the questions I know with Pat Ruddy that we talked about, and who works with the Irish dancers. Yeah, they're seeing somebody dancing in a shoe size smaller next to them. They're going to try and squeeze their foot into. So I mean, footwear as a whole, you know.
Yeah, well, the thing, you know, I've always said that, you know, it's been something I've been mentioned for a long time, even from an interview back in the late 70s, that, I mean, all dancers get sprains, tendonitis, bone injuries, contusions, stress fractures, skin problems. But the injuries that you will see in the genre are either caused by the technique and pressure caused by the shoe, or the lack of protection from a shoe. If you're a barefoot dancer, again, you can't win for trying. Your Latin dancers and your ballroom dancers, you know, they're always in releve. They have a more unstable ankle because the posterior talus is not as tight in the mortise when you're in plantar flexion. They have a high tendency to have, especially men, neuromas. They also have a lot of MTP, instability issues, plantar plate issues, and sometimes stress fractures. And these are things you'll see in your...
so that sort of answers Megan Maddox from South Africa's question, which was about with the ballroom Latin dancers on their heels and the different injuries from in ballet.
And then the ballet dancers, they have, again, with the extremes in dorsi and plantar flexion, they have impingement injuries and instability in the ankle. The FHL that I was saying, the ballet dancers, in order to force that appearance, like you say, that elegant look, sometimes they don't quite have enough, and this is something I published in terms of ranges of motion, sometimes they don't have quite enough range of plantar flexion in the ankle, so they try to cheat and get extra plantar flexion in the midfoot. And that's not unusual for them to get sprains of the dorsal midfoot, you know, and also it's not unusual for them to get compression fractures at the inferior base of the lesser metatarsals for that reason. And that's where your point shoe strength comes in handy.
That's actually really well leads into, it's like, you know, the questions, but I haven't actually prepared for this one. Georgina works with that. She's in New Zealand, in Christchurch. That was it. That was the management of a Liz Frank injury in a hypermobile foot.
Well,
on
and
Pointe.
Right, your Liz Frank injury is a very, very serious injury, and if it's not attended to properly, it can lead to really protracted downtime that eventually is going to have to be followed by surgery anyway. Liz Frank injury, obviously, when you're looking at it, the most sobering sign, I would say, is the standing weight-bearing X-ray, where you see the base of the fifth metatarsal winds up being dorsal to the first metcuneiform joint in a standing weight bearing. Also, when you look at an AP view, you'll see the flex sign between the first and second metatarsal, or you may see more than 2 millimeters of distraction. The MRI, if it shows a significant tear to the Liz Frank's ligament, then obviously you're looking at surgery, because this is going to be a long injury. The rehab is about a year, but they can come back. For management of more minor Liz Frank injuries, and it's pretty tough to get PRP into that spot too. I would have somebody be on crutches for at least 4 to 6 weeks, and then a cam boot for maybe another 4 weeks, and then start rehab, including.
And then she alluded to in the hypermobile dancers, especially in that midfoot.
I guess a hypermobile foot could lead to, when you say a Liz Frank's injury, are we talking about a fracture sprain or a sprain, or
just managing Liz Frank injury? So she didn't specify exactly what, but maybe, yeah. Okay.
You may see it. I don't know if that's something you would see in a long-term dancer or a more early on dancer. If it's a minor sprain just starting, obviously I would temper things down depending on the degree of injury, and probably I'd work on strengthening the foot intrinsic muscles, strengthening the core muscles, strengthening everything that can possibly slow down that sprain to the hypermobile foot.
So Megan, again in South Africa, that was one of her questions, was that the ballroom and Latin dancers don't really seem to be that, they take as much battering and forces and use and abuse, but they don't really seem to do nearly the same amount as foot preparation. So those intrinsic working that the ballet dancers.
Sure. Well, I think the advantage ballet dancers have is that many of them are part of a company that has a pretty big endowment. And they have physical therapists that are just chomping at the bit to be part of that company. And they're all highly into research, and they're all very dedicated. On the other hand, ballroom dancers are not privy to such close medical attention. Therefore, they don't have the screening. And one of the things I would say that the ballroom dancers should do is, well, what position is your foot in, or what activities does your foot do that are abnormal compared to normal walking? They're in a thin-soled shoe, they're on hard floors, they're landing hard, they're turning, they're on the ball of the foot. How can you protect that? Okay, number one, obviously, make sure that your peroneal strength is good. Make sure your posterior tibial strength is good to stabilize you so you don't have to compensate. Make sure that your intrinsic foot muscles are strong. Make sure that the core muscles are strong to slow down landing. I would just say, those would be the basic things that I'd look for. Keep your shoes updated regularly. Yeah,
because people don't realize. I mean, a dancer will go through a point shoe in a week.
A week? I'll give you an example. I had a dancer from, let me just give you a quick example on that. I had a dancer she was from a big company in New York City. She had a stress fracture because she let her point shoes get too old. Her company was going down to Jamaica to perform for a weekend. She took 20, because she sweats a lot and point shoes can deteriorate, the glue deteriorates more quickly when your foot is sweating. She took 25 pairs of $125 point shoes down to Jamaica with her, and she went through every single pair between the rehearsing and the performances. It's not unusual for a dancer, and the City Ballet and the Royal Ballet spend between $4 and $8 million a year on point shoes. So, and it's not unusual for a dancer to go through 3 pairs of point shoes on a weekend.
Okay.
Performing. One other point about point shoes. Can I make about point shoes? If you have a performing dancer, very often during the more rigorous part of a season, like if they're doing Nutcracker and then the repertoire after that, they will start to get soft corns or neuromas or other compression problems at the MTP joints or toes, because the foot actually gets larger during a heavy performance season. And they need what's called a heel pin larger point shoe when they're in their heavy performance season, because it's important for the point shoe to be nice and snug for stability. But if the point shoe is too snug, that's when these injuries don't go away. Sometimes they will have a maker make a slightly larger point shoe for the busy performing season.
And again, that was Georgina's question. How much emphasis would you put on the strength of the point shoe shank in the midfoot stabilization during rehabilitation?
Well, that's an excellent point, and that's also something that you have to consider in a young dancer, the strength of the point shoe shank. Obviously, you want to have the kid be able to learn how to go up and balance on point, but you don't want them to stay in a shoe, and the same thing would go for somebody who's rehabbing. You don't want to stay in a shoe that's too rigid in the shank, because it'll take away some of the strength in the metatarsals, unless it's what you're used to and what you've successfully danced in your career ahead of time. Because the main reason for any injury, I don't care if you're talking about a person that's delivering the mail or a professional ballerina or a soccer player, is a too abrupt change in your equilibrium. I'm just going to give you one more point on that if we have time.
We have plenty of time, Tom. All the time.
Great. Okay, good. Well, many years ago, I treated several dancers from a company in the city for a big festival for a modern dancer. And the ballerinas who'd been used to dancing in point shoes, all of a sudden for this festival, all of them were dancing barefoot. And I had seven lead ballerinas came to see me. Every single one of them had a second metatarsal stress fracture because they'd upset their equilibrium and they were not wearing their point shoes. So the most important thing is, don't change the equilibrium that a person is used to if they're not injured. There has to be a really good reason to change the shank. Keep them what they're used to, but obviously during rehab, you can use a stronger shank, but if they've been used to, once they get stronger, a more medium shank, that's what they should go for. Various reasons for different shanks.
And of course, I mean, given the immense, metatarsal head support on Pointe. How much input is Tom able to provide in assessing point shoe suitability for the dancers recovering from, first metatarsal hyperextension injuries?
First MTP joint hyperextension injuries, yeah. Well, I think that should be covered pretty well in your normal point shoe. If you're, say, a recreational ballerina and you're not dancing with a particular company, and you're not sweating a lot, and the shoes aren't that. There are a lot of things to look for in terms of how alive or dead would be the terms for a point shoe. Usually more than 40 or 60 hours dancing in a point shoe is going to be dead. If the toe box is breaking away from the shank, if the shank is easily bent, if you're wearing through the tip of the toe, obviously these are indications that the shoe is dead. But a normally alive point shoe should be able to stabilize a hyperdorsiflexion injury. You may want to go with a more rigid shank for a while, but again, keep strengthening your toes. I don't think your ballerina should have too much of a problem with a hyperdorsiflexion injury as with respect to the shank of the shoe. I'd keep with something that you're used to, maybe a little bit firmer shank. It really has to do with getting the ligament more stable, again, Prolo, PRP, strengthening of the toes, taping for a while as necessary. I want to talk a little bit about taping for MTP insufficiency. You guys use that Boudin type tape for MTP insufficiency. If you have, one of the things I've seen is if a person uses it for too long, it can actually, that little, it looks like the little breast cancer loop shape that it has, if a person uses that taping for too long, it can actually induce a long digital extensor tenosynovitis, because when a dancer lands, they land on the ball of the foot. Therefore, they have to dorsiflex their toes when they come in for a landing, particularly a male dancer. If you have the opposing force of that Boudin type tape, if you don't need that tape anymore, A, you'll be weakening the intrinsic plantar flexors to the toes, and B, you're going to be creating an extensor tenosynovitis. So you can't leave that tape. It's good. You can get them dancing, but they can't leave it on indefinitely.
And that's also the same thing with metatarsal domes or pads as well.
Metatarsal pads, I think, in a dancer, they may as well be in their back pocket, because as soon as they releve, and this is for a walker too, as soon as that person takes the heel off the ground, the metatarsal pad is no longer functioning. If they have a particular metatarsalgia, say a second or third or first metatarsalgia, I prefer using a felt pad directly under, as long as there's no other involvement, the contiguous uninvolved metatarsals, to offload it at the very time that they're on the ball of the foot. I'm not a big fan of met pads. Also, I'm not a fan of met pads because I think they, A, weaken the toes because they do a little bit of plantar flexion, and B, they encourage a person to start losing strength in the calf and the peroneals because they have to keep their weight back in order to make the thing work. So I'm really not a fan of metatarsal pads.
No. And of course, dancers they have their own little tweaks that they make to each individual. They have their little toolkit with them, and they're pairing off, and they're slicing pieces, and they're roughing up certain things because they know they want to get more grip on the stage for them. Right. So they all have their own little tweaks and techniques that they use.
They spend a lot of time working on their point shoes, and imagine they have to do this 3 or 4 times a day. It takes
got to break them in. I mean, they got to
a weekend, right? And they have to cut the shank on a bias, the cardboard, and they use the little cigarette lighter to heat the ribbon so it doesn't fray. And they have their special ribbon placement and splicing elastics into the ribbon and bending it in certain ways. And some point shoes now have plastic shanks that you can actually heat with a hair dryer, and then you shape it to your foot, and then you can put it in the refrigerator so it stays that way. So there's it's a whole cult, how you're fixed. I have a video, a wonderful dancer from Alvin Ailey, from Dance Theater of Harlem, did a video for me of the work that they have to go through to do their point shoes. City Ballet has a video on it, and I think some of the other companies too. Yeah, it's quite a technique.
Yes, and yeah, because that's the shoes are hugely important, and individually, and then the dancers themselves, and again that journey of the dancer back to from the they're very, very busy. They don't have very much social life. They are elite athletes. That their days are taken up practice, treatment, what do you call it? Sorry, rehearsing, performing, and also like what do you call when you go to try and get the job? What's the I'm just it's forgotten. Screen call.
The auditions, but the thing
Auditioning.
Yeah.
Like auditioning, yeah.
They don't have, I mean, especially the young dancers away from home, you know, School of American Ballet or the big city schools. But the thing about that I've always sort of been an outsider on and a little bit jealous of, but also loving of when I see dancers is, you know, they may not have much outside social life. Some of them do, especially when they're getting started. But once you're a dancer, a professional dancer, or you've been dancing for a long time, you're forever a part of the family.
Okay.
And, you know, everybody pulls for everybody else. And it's a beautiful thing to behold, you know, and I'm really glad for that reason. So it's you know, it's a very, can I tell you a little story about how a kid got into the dance world? So his father was one of the first chairs in the City Ballet Orchestra. And this was the days of Mr. Balanchine. And his father told me this story. Mr. Balanchine used to like to sit on the side of the stage and listen to the rehearsals because musicality was his big thing. And after a rehearsal, Balanchine was leaving, and the gentleman, the first chair in this particular instrument, walked up to Mr. Balanchine and said, "Excuse me, Mr. B, Mr. B." And Mr. Balanchine said, "Yes." And he said, "Mr. B, do you think my son should study dance?" And Balanchine said, "Yeah, well, how old is he?" So the dad said, "Well, he's 12. Well, Balanchine said to him at first, "Sure, make him go to some school, you know, he'll get poise and confidence and things like that." So the dad was really dejected because he thought that Balanchine was going to say, "Yes, sure, he can come to School of American Ballet, the elite school for New York City Ballet." So the gentleman turned and he was walking away from Mr. B, but Mr. B said, "Well, wait a second, does your son play any musical instrument?" So the father said, "Well, yes, he can play anything by Mozart. He's 12 years old, anything by Mozart in any key on the piano, anything by Mozart." Now, Balanchine really respected musicality. So he said, "Oh, really? Well, you send him to the studio tomorrow. I'm going to give him a personal audition." The kid passed the audition. He got into School of American Ballet, 12 years old. He put a sign on his bedroom door, "New York City Ballet, watch my smoke." 4 years later, he was in the company. Yeah. So I just think that's just a sign of the dedication. It always gets me.
Yeah. The dedication is stupendous. So I just got a question in from Sean, a colleague, Sean Savage in Northern Ireland. Sean works in Belfast, and he sees quite a few Irish dancers, and he's seen recently quite a few navicular stress fractures.
Mm-hmm. The navicular stress fracture.
The reason for this, would you have any reason for this? Why and this injury, an injury prevention then?
Well, the navicular stress fracture, first of all, it's often misdiagnosed and it's often mistreated. You know, a navicular stress fracture is a serious injury, and I demand crutches for at least 4 weeks and then a cam boot thereafter. And then obviously all the rehab that follows. The navicular, the central portion of the navicular doesn't get much vascularity.
Yeah.
It's very prone to compression injuries. And I often see navicular stress fractures demographically, although it is an unusual injury, more in the younger dancer than in a more mature dancer. I'm not sure why that is, but you know, and then there's Kohler's disorder, which you have to differentiate it from too.
Yeah. That's right. I've only ever seen, I saw two Kohlers. I took 2 Kohlers within 2 weeks, and I didn't see another one for like 18 years.
Right. Well, well, you know, it must have, maybe it was contagious. You never know. So, but I think in an Irish dancer, one of the reasons why you may get a more likely to get a compressive injury of the navicular is because of that 17-degree thick tap that they have at the tip of their front part of their shoe.
In the heavy shoe. Yeah.
The hyperdorsiflexion of the great toe causes the hyperplaniflexion of the metatarsals. And I think that can cause more compression to take place in planiflexion of the ankle. Same pressure coming from the ankle side of the navicular can cause a compression injury there. That's So really what to do about that, I guess, is core strength, toe strength, lateral ankle strength so you don't bias too much weight medially, glute strength, things like that, and obviously concerted and careful rehab.
Mm-hmm. Yeah, and David McGettigan, another colleague in Ireland, said his questions in previously, and how do you approach feet that don't move well enough?
Well, that brings up a very interesting and very sensitive point. Sometimes, and I'm trying to put a book together about this so that kids don't invest a lot of hope, time, and money and dreams into a dance career where they may not have it. And I've seen a lot of kids in college coming in and they never should have been made a dance major, and now they've wasted their college education time. A lot of it has to do with screening. Now, somebody who doesn't have good range of motion may be more suitable to a African dance or jazz dance or tap dance, or maybe even certain types of modern dance. But if they've got their stars in their eyes, and even more importantly, if their parents have stars in their eyes and the kids don't, you have to somehow tactfully mention that this should be selected away early and they should be pointed in another direction. It's very difficult. Kids that, just a little sidebar, there's this injury that I call the hover phenomenon. Sometimes parents are more interested in their kid becoming a dancer than the kids are.
Yes.
The kid will come in with an injury that just doesn't make sense historically. It doesn't pass the right tests in the physical exam. And as you place your hand over the foot, they start crying. And that's why I call it the hover phenomenon. And but that particular type of presentation requires a lot of imaging and diagnostic verification, because there may be something wrong there. You can't just use what I'm saying, but I do see this, and not that infrequently.
Mm-hmm. Yes. Yes. And as you say, well, of course, like in any elite sport, it's, very few are chosen. Very few make Saturday night front and center.
Yeah, there's a lot. Very
few make the NFL. Very few make the Premiership football. And again, those parents on the sideline, possibly living vicariously through their kids. But there's only one principal dancer.
Right, and they go and sometimes the parents will take the kid from doctor to doctor until they hear what they want to hear. And
John says thanks for that. He really enjoyed that the answer. And do you individualize your approach to strength training before do you individualize your approach? Do you individualize his approach to get more movement in joints before you'd start with strength training?
Well, funnily, the Kitchen City Ballet have been mobilized. I'm sure you guys do that too, to get the ranges of motion up. I think it's both two separate issues and a similar issue. Obviously, if somebody is weak, even if you mobilize them, you have to get the muscle stronger.
Yeah.
And if someone had an injury leading to a low range of motion, you have to improve the range of motion for the muscle to work through the entire functional range.
And we talked about that earlier, is that, there's no point just giving strengthening if you haven't identified the cause of the injury beforehand and identified that. And then also that's going on, especially with young dancers and growth spurts and different injuries at different stages. And of course, then again, with young, especially the female, the girl dancers, and again, diet and hormonal changes. I mean, it's a whole soup of.
Right. Well, that's the female athletic triad. The fatigue with or without eating disorder, the delayed onset of menarche, which is sometimes up to the age of 16. They're more prone to stress fractures. The good thing about the delayed onset is that it allows the female form to be less prone to injuries, especially when it comes to the hip width. if people start dancing on Pointe later on, say after adolescence, they're much more prone if they develop a wider hip because they have the normal onset menarche, which is going to increase the patellofemoral angle with their jumping. But if they begin their dance training early, like in their pre-adolescent years, a few pre-adolescent years, 5, 6, 7, and then they continue on, they will have a narrower hip, and it's less prone to injury. But of course, through that time, they're more prone to stress fractures and other injuries because they may not have the estrogen keeping the calcium in their bones where they're stronger. So it's a fine line, and but another thing that a subtle thing is, this is especially if they're doing elite training, when the kids have to learn not only about being healthy, but they also have to learn psychologically to come to grips with the frequent injuries that they're going to see throughout their career. 80% of professional dancers will have had
because
foot and ankle injuries.
yes, because the foot and ankle is the most commonly injured area. Yeah, and they say yes, nobody goes through their career without an injury.
I've had
very lucky.
One 33-year-old dancer who came to see me, who had I guess I was a jinx, until she came to see me. Up until that point, she had never had an injury. This was about 5 or 6 years ago, and I still remember her. It's so rare. The other thing about the young dancers and the screening that we were talking about, if the child is fortunate enough to live in an area where there are different dance genres taught, they are fortunate, because sometimes they'll go to a school and a teacher may encourage them to continue dancing even though they may not have the physical makeup required for ballet. So, it's just something that parents should keep in mind. Get another opinion if the kid is having more injuries than the other kids in the class. Why are they having the injuries? And is it something that you're going to have to fine-tune the kids' sights early on? So.
Yeah, as you described it, if they have stars in their eyes, though, it is.
Sometimes it's what you need, and then sometimes it's what undermines you.
Yeah, and I'm sure you've had to have some very real conversations.
It's the toughest thing. It's the toughest thing. It's tougher than telling a dancer they have a seasoned dancer that they have a bad injury. They're ready to come to grips with it. But it's tough to tell a kid that they shouldn't be doing this type of dance. And sometimes, I would say only 50% of the time do I get my point across, as much as I try to prove it. So with the ranges of motion.
Like any injured elite athlete, and that's what we covered in the intro. The first question out of their mouth is, "Doc, when can I get back and dance?"
Right. That's
my running cars, my anything else. It's like, yes, but I know all this, but when can I go back? When can I go back? And so we touched on that last night in a talk we did. And again, as you said earlier on, this has been a great time for recovery on injury. But when dancers say there's with other sports, you have your pre-season and you get a chance to sort of rehabilitation. But on the season, if they've got to get out to perform a couple of on a match once a week, on an NBA court 2-3 times a week, on dancing six nights a week, and a matinee on a Saturday afternoon, when you're in season, you don't get really that time for the recovery and then to actually really address the injury.
Right. Well, they usually have very few dancers come in with an injury. Most dancers come in with 3 or 4 injuries. Some of them they've been dancing through for 3 or 4 years. Yep. So the best question would be, when can I safely get back to dance? But that's not the question they ask. When can I get back to dance? Because I'm already used to having this Achilles tendonitis, posterior impingement, sprained first MTP joint, and partial tear in my peroneal tendons. But I still have to do my 6 pirouettes when I enter the stage. When can I do that safe enough so that I don't get another injury instantly? That's the tough part. And there is no really good answer, because a lot of it has to do with the mental status, not only physical status, and the fortitude that these dancers have. Most of them, not 100% of them, but most of them have that in droves. And again, that's one of the inspirations that I've benefited from. They are the ultimate professionals. So there's no really good answer on that. But you know your tissues, you know, MRI, ultrasound.
See, that was. I've just been thinking since you mentioned it earlier on, and then I've just sort of realized why it probably is. I thought there would be so much competition because you said the dancers, once they get accepted into the group, they all support and help themselves. And I always was under the impression that it was very, very. But then I've just realized they're dancing as part of the team.
They are, and the other thing is, well, that's part of it. There is a lot of competition, and you know, dancers are always looking over their shoulder because that's one of the reasons they dance injured, because if they don't, then somebody A is going to take their job, you know, B, they'll lose the status, C, if they go on workers' comp, they're going to lose salary. But on the other hand, a dance company only has a certain number of members.
Yes.
And it becomes more likely for others to get injured if, you know, 20% of your core is out injured. So, you know, there is ultimately everybody is pulling for everybody else, but they also want their jobs.
Yes, and I do know that, you know, certain shows and certain groups it is a lot of times if you can't, I mean, it's very ruthless. It's extremely ruthless.
Just to give you an example of that, there was a show, I'm being very careful trying not to name names here today. Yep. There was a show on Broadway where there was an elite young dancer who had the lead role in the show. First of all, several of those young kids came in to see me with exactly the same overuse injury. And that's usually when the problem happens, is from a rehearsal when they're doing the same thing over and over and over again until they get it right. But when these kids were auditioning, they had a line of kids in front, and then there was another line of kids behind them. And one kid came to see me because as he was auditioning, he was in the front line. One of the kids behind him stopped drinking for a second, actually pushed him off the stage down into the orchestra pit. That's how competitive they were. So, you know, neither one of them got the job. Yeah. Unfortunately, the kid who came to see me was very badly injured, and the kid who just got out of reform school was too old for the job. You know, so it was.
It is only water still at this time of day, Tom.
Okay, no, I was just saying I didn't want you to drink when I told you the punchline.
Oh yes, sorry. And yeah, because I remember a physio colleague went to him in terms of competitiveness, and this is a really. Yeah, he went as a part of the physio, and Dave's actually really good. Works in Melbourne, and he's right beside the Circus School, which is a feeder school for Cirque du Soleil. So Dave sees like loads of interesting stuff, jugglers with neck pain, and all the, you know, I mean, again, elite. He went on a bursary to China with a couple of others, and he went to see the gymnastics setup for the Olympic program in China, and it was brutal. What they were doing. So one of their party was crying because of what the trainer was doing to the kids. And what the trainer turned around to and said to her was, "That's why you're not winning gold medals."
Yeah, if
they don't break, you're good. If they train them till they break them, and the ones who don't break are the ones who go on. I mean, well,
the Peking Opera Ballet sent their company to the United States in, it must have been 20 years ago. And the dancer came to see me. He must have been in his thing was he would jump without preparation from the ground straight onto a tree stump 3 feet high. No preparation, bing, spring right up onto that tree. No chance to absorb shock. His ankles on x-ray looked like 7 on the Richter scale. You know, in his late 20s, and he still had this. But you were saying about the Cirque du Soleil. Can I tell you a little story about Cirque du Soleil?
Yes.
The dancer came to see me. She had what was called sesamoiditis, and she anticipated that she was going to have her sesamoid removed. So they just asked me to try to make some kind of pad to protect her sesamoid until after the season was over. And that was actually Cirque du Soleil. After the season was over, they could remove her sesamoid. So, I mean, I was palpating around, and I couldn't find any pain when I palpated, which is pretty unusual for a sesamoid having to come out. I took a look at her MRI, and the sesamoid looked absolutely fine. But there was a slight nidus of hyperintensity just medial to the medial sesamoid. I said, that's interesting. So I said, what could that be? Maybe that's the problem. So I took a look at her ballet slippers. Now, she had defected from Russia. And the ballet slippers were the only things that she took from Russia. Everything else she left behind. So I said, may I see your ballet slippers? She said, yes, but be very careful because they're the only things I've taken with me from my home. I said, okay, I'll be very careful of them. So I looked inside them and I said, okay, well, I'll do you another favor. I just want you to releve, go up on the ball of your foot and come down again barefoot. Does that hurt? She said, no, it doesn't hurt. I don't know what to do. So I said, I don't know how to make a pad for this. So then I took a look inside her ballet slippers, and these old ballet slippers had a very hard encrusted seam, suspiciously on the inside, right where that little nidus of inflammation was on the MRI. So I said, well, let me do this. I said, okay, put your ballet slippers on and give me another releve. And she tried to releve. Oh, a lot of pain. So then what I did was I marked the seam inside those ballet slippers with a transfer pen, put them on. She did the painful releve again, took them off, and I looked at the little line that had transferred to her foot, and I palpated it. I said, is that where it hurts? She said, yes, that's the first time anybody's ever been able to palpate it to find the pain. I said, well, let me do you a favor. You mind if I cut a hole in your ballet slippers? So she said, so I said, well, let's try it. So I cut the hole right where that little mark line was, and she relevated, and she said, no pain, this is wonderful. But then she started cursing in Russian, and I figured she was really mad at me because she was cursing. As it turns out, she was mad at those ballet slippers. So that, sometimes there's a little shoe gremlin that you have to be aware of.
You left it behind. Yeah, and of course, so something, the extrinsic factors as well as, and there's certainly surfaces that dance on, and I'm aware of, again, another company will remain nameless who, when they were, training, the guys ended up the concrete floor.
Right.
They don't look after them. The injuries coming from that, and again, and I know you've in Radio City, you've treated a lot of Rockettes. Pat, who I mentioned before with river dance, he said when he first went there, because it's the hydraulic stage where the Rockettes pop up out of him stuff. He says his legs still are suffering from the after river dance went back there again, they had their own sprung stage on top of that. But he says he never forgets that stage. He still feels it in his legs.
Yeah, well, that's the same thing that's happening with in soccer, just for a little sidebar. The women's soccer, even the Olympic athletes, they're usually training and competing on artificial turf.
Yep.
And the guys, that's one of the things they're petitioning for, to make equality. And the guys train on real turf, real earth. And the incidence of stress fractures and tendonitis is much greater in the gals because that's a much harder and less forgiving surface. So it happens across all the genres.
The local, and as Paul Cheshire is still watching one of the Dundalk, which are the League of Ireland soccer champions, they have an artificial pitch surface, and there's a couple of those who've gone in, and a lot of players don't like playing on that, especially, I remember seeing a young guy one time who was signed, and he'd already had a cruciate reconstruction, and I think his surgeon had sort of told him not to, because there's more grab and more on the surface.
And not only that, it's dangerous because the rubber that they put in between those artificial blades of grass is made from tires, and that they've discovered, Mount Sinai has discovered that material is carcinogenic.
Okay.
So, and that's all they have for their soccer pitches in New York City, even for the kids. So it's pretty tough.
Yeah. So, we've covered a huge amount, and we've still got questions coming in, but, the time has probably caught up with this again. And, I would certainly ring, I'm sure we'll have even more questions coming through, and this will just bring more people, make them think more. So we'll draw to an end today, Tom. There were certainly, people will take a lot of certainly golden nuggets from this in terms of clinical practice for dancing and for normal, whatever normal is, patients. It's been phenomenal. It's been a pleasure.
Same.
And we will do this again. I'm sure there will be the demand for this. It will stimulate a lot of response. And how can people find out more about you, Tom, and where can they find you? And I mean, and you say your body of work is with dance is huge.
Well, it's just if you want to get some ideas, you can look at the website. You know, I think it's tnovelladpm.com. You know,
Yes.
pretty sure that's what it is.
Okay.
So, and I keep updating it. You know, keep tracking my website people to make sure they update it for me. So, but I must say, this really has been a great. You're a great guy. I love your questions. I'm so happy your audience is interested. I love their questions. And I've really enjoyed this very much. I'd love to do it again if we can sometime.
Yes, no, we definitely will, Tom. So that's bye to everybody on Facebook who has tuned in, and thank you very much. And again, absolute pleasure, Tom. Thank you.
Thank you. Bye now.
So, okay, so yeah, we can talk now.
Oh, okay. That was good.